ठीक है छोटू लोग. So let's talk about the respiratory system. In the main exam, you can expect 2 to 3 questions from this particular chapter. The functional unit of lung is called as a sinus. It is made up of rada, respiratory bronchiole, alveolar duct, and alveoli. Now we know that our right bronchus is a little vertical as compared to left bronchus, and that is why the foreign body gets dislodged there. In the respiratory tract, the epithelium is pseudostratified ciliated columnar epithelium. You see single layer, which looks like multiple layers. That is why pseudostratified. The layers are in which sequence? MSMC. The mucosa, submucosa, muscularis, cartilage, and in the submucosa you have glands. The glands produce this is your pseudostratified ciliated columnar epithelium which you have. Okay, so one layer of cell, but looking like multiple because the nuclear placement is up and down. This is the biopsy from the alveoli. Type 1 pneumocyte plus elongated type 2 pneumocytes. Function of type 1, gaseous exchange, type 2, surfactant production and repair. The diseases of the respiratory system which you're going to read are acute and chronic. In acute, we'll be discussing about one disease, and that is your ARDS, and in chronic, it will be obstructive and restrictive. In obstructive, it is difficulty in putting the air out. In restrictive, it is difficulty in taking the air in. In obstructive diseases, we'll be discussing these four: emphysema, chronic bronchitis, bronchial asthma, and bronchiectasis. Whereas in restrictive, we'll be discussing about pneumoconiosis. Now, coming to this ARDS, acute respiratory distress syndrome, this is also called as DAD, diffuse alveolar damage, hyaline membrane disease, stiff or shock lung. Now, what happens in this? Due to any infective pathology, most commonly, like pneumonia, the antigen enters, it is taken up by the dust cells, the alveolar macrophages, which release interleukin 8, which will actually call the WBCs, the neutrophils from the vessels into the alveoli. And when these neutrophils come inside the alveoli, they're going to release some enzymes like proteases, which are going to kill the entire alveolar epithelium. That means complete destruction of type 1 and type 2 pneumocytes. So no surfactant production, no repair happening, no gaseous exchange. And that is why, because the entire alveoli is gone, diffuse alveolar damage, because this all will be replaced by a pink color hyaline material all throughout. So hyaline membrane disease. Because no gases exchange, so shock lung, even giving oxygen from outside won't help. And because everything has gone fibrotic, that is why stiff lung. When the WBCs are leaking from the blood vessels, what else would leak? You would have these plasma coming in the interstitial space, which will lead to non-cardiogenic pulmonary edema. So the interleukin responsible for ARDS, interleukin 8. Cell responsible for ARDS, neutrophils. Types of cell damage in ARDS, type 1 and type 2 pneumocytes. Most common cause of ARDS, that's your pneumonia. Obstructive disease, first disease emphysema, destruction, dilatation of the smaller airways. Smaller airways से मतलब हो गया sinus मतलब rada. Now, emphysema, generally, if somebody asks you what is the most common cause, it is always and always smoking, but it can be genetic too, and that is autosomal recessive in location. Now, the thing is that we all have genes like PIMM gene. So PI is protease inhibitor. So we have this inhibitor gene in MM form. If one gene out of these two are mutated, it becomes a carrier state because it is autosomal recessive. So homozygous state can only cause the disease. So PIZZ will cause the disease. Otherwise, if it's a single mutation, patient becomes carrier. Now, in any uh, organ, there are destructive and restrictive protective mechanisms they are working. So this destructive mechanism of the lungs is the production of elastase enzyme, which is going to cut the elastic fibers. The protective mechanism for the lungs is anti-elastase enzyme, which actually is coming from the alpha-1 trypsin produced by liver. So liver is also helping in keeping our lungs healthy. If there is any liver disease, alpha-1 antitrypsin will not be released, and if alpha-1 antitrypsin is not released, the patient will not have a proper respiratory system as well. Whereas this elastase enzyme, they're released by the neutrophils, the granules of the neutrophils. Now, emphysema, most common cause is smoking or alpha-1 antitrypsin deficiency, which will increase the elastase activity because you're not having anti-elastase enzyme. It will destruct the lung or the tissue parenchyma, and emphysema can happen. Now, this emphysema can lead to dyspnea, obviously, pursed lip because the patient is always doing like this, because something is destructed, it is something is obstructive inside. Then they are called as pink puffers because they're able to maintain the partial pressure of oxygen in the blood. So they're not going in the cyanosis in the initial part of the disease. So they're called as pink puffers. Severe problems can lead to barrel-shaped chest, flattened diaphragm, and core pulmonale, that is right side heart failure. Then sentry assigners, the four types of emphysema, sentry, pan, paraseptal, irregular. You have to learn these two, the sentry and pan. The most common type of emphysema is sentry asigner. The second most common is pan. In sentry asigner, you are having proximal sinus involvement. That means what is a sinus? Rada. So R involvement, respiratory bronchial involvement. Whereas pan assigner, everything gets involved like in this. The cause of sentry assignment is smoking. The cause of pan-SR emphysema is alpha-1 antitrypsin deficiency. Then comes your chronic bronchitis. It is production of sputum for more than 3 months for consecutive 2 years in the absence of any known pathology. Most common cause always will be smoking. And emphysema, very important, but chronic bronchitis is not associated with amyloidosis. Very important. And chronic bronchitis leads to production of mucin more and more. So there are more pathogens getting trapped in that. So a patient who is having chronic bronchitis is at more risk of going into severe secondary infections. This continuous injury to the epithelium of the respiratory system because of various causes, most commonly smoking, it leads to metaplasia first and then dysplasia and then finally cancer production, the anaplasia. And in chronic bronchitis, because the mucin is narrowing down the lumen from where the oxygen can go in, the air can go in, so it increases the vasoconstriction because of low partial pressure of oxygen, and it can lead to pulmonary hypertension, which can lead to right-sided heart failure. For a chronic bronchitis, we have to remember the reed index, where the length of the respiratory epithelium, total length, is more occupied by the gland layer. So gland layer become thick out of the entire respiratory epithelial thickness. This is called as reed index, and in normal person it is less than zero point 0.4. But in any patient who is having chronic bronchitis, it will be more than zero point 0.5. That means the gland layer will be more than half of the total respiratory epithelial thickness. Okay. For bronchial asthma, it is allergic more commonly, and that is your extrinsic type of bronchial asthma. But it can be non-allergic, which is your intrinsic type of bronchial asthma. It's type 1 hypersensitivity reaction. And because it's type 1, so you have interleukins 4, 5, and 13 causing it. But it can be due to some other triggers too. The gene responsible for increasing the severity of the bronchial asthma is ADAM gene and YKL genes. And E से बेटा E से E antibody, so extrinsic wala is allergic, intrinsic wala is non-allergic. Okay. With bronchial asthma, remember Samter's triad, where you have intolerance of ASA, namely the drug is aspirin. You have nasal polyp and you have asthma. Okay. Then in the sputum examination of asthma, you will have three C's, the Crayola bodies, the Kirschmann spiral, and Charcot-Leyden crystals. Three C's, bronchial asthma, type 1 hypersensitivity reaction. So if they ask you what is the TH cell requirement, so for type 1 hypersensitivity, TH is 2 because the interleukins we are secreting are 4, 5, 13. So TH2 secretes 4, 5, 13 because it's an allergic kind more commonly. So allergen is activating TH2 cell. So TH2 cell is the main cell for bronchial asthma. Okay? And you see sputum late reaction, more than 2 hours, Kirschmann, Crayola, and Charcot. We have done this in type 1 hypersensitivity. Then bronchiectasis, again, the most common cause is smoking. It is the destruction and dilatation of larger airways, where we are talking about the bronchus basically. It can be genetic, it can be acquired. Again, all the same causes: alpha 1 antitrypsin deficiency, cystic fibrosis, Carter syndrome, which is primary ciliary dyskinesia. And the mnemonic for Carter syndrome we have done is BDS. You are having bronchiectasis, dextrocardia, and this sinusitis, allergic sinusitis. Okay. Why this occurs? Because of defect in the dynein arm of the cilia. And infertility somehow is not associated with Carter syndrome, so therefore it's not a part of the tetrad. Carter syndrome only has a triad. Then in bronchiectasis, always remember you see honeycomb appearance and you see tram track appearance. Okay. Then in pneumoconiosis, we all know it's the most common occupational hazard. Coal dust, anthracosis, upper lobe involvement, Three phases: asymptomatic, simple, and complicated. You see colmacule, which is your coal dust associated with macrophage together. And TB risk and lung cancer risk is nil, zero. With silicosis, this is the most common pneumoconiosis. It is due to silica dust, upper lobe involvement. On HRCT, you see ground glass opacities, and it will give you eggshell calcification. Lung cancer and TB risk is maximum. तो सब कुछ याद रखना जरूरी है. Most common is silicosis. On HRCT, eggshell calcification, ground glass opacities. On X-ray, eggshell calcification, and TB and lung cancer risk is maximum. Asbestosis has come the most amount of times in your exam. Now, asbestosis is due to asbestos dust, which is a little heavy dust, so it will be involving the lower lobe because it will settle down. And you see asbestos body in the sputum. What are these asbestos body? Asbestos dust lined by iron. They are also called as ferruginous bodies. And छोटू, प्लम्बिंग यूनिवर्सिटी, शिपयार्ड यूनिवर्सिटी, सीमेंट इंडस्ट्री, सब में एस्बेस्टोसिस का प्रॉब्लम है. ठीक है. एंड इफ दे से प्लूरा इन्वॉल्वमेंट, भाई इट हैज टू बी एस्बेस्टोसिस. If it's a question on pneumoconiosis and they are seeing pleura involvement, always think about asbestosis. ठीक है छोटू. Most common cancer involved with asbestosis is lung cancer, और lung में भी कौन सा है? Bronchoalveolar cancer. But most specific is malignant mesothelioma. It's a plural cancer. Malignant mesothelioma. Okay. No TB risk, but maximum lung cancer risk is seen. Lung cancers, most common are secondary or mets. From where? From the breast. Benign cancers, nobody's going to ask you, but still carcinoid tumor of the lungs, benign carcinoid tumor, it contains Kulchitsky cell and it arises from the neuroendocrine cells. Malignant, mein we have four: squamous, adeno, small, and large. Large padna hi nahi hai. Squamous, most common in India, adeno, most common worldwide. Small cell carcinoma, it is arising from the neuroendocrine cells. So, and this is also called as oat cell carcinoma. This is worst prognosis actually, small cell. क्या क्या बातें याद रखनी है बेटा? स्क्वामस एंड स्मॉल, दे आर मोर कॉमनली मेल्स, बट विच इज द मोर कॉमन कैंसर ऑफ फीमेल? एडिनो. द मोर कॉमन कैंसर फॉर नॉन स्मोकर्स, एडिनो. Because small and squamous, they both are what? Smoking associated. But most commonly, most strongly associated is small. ठीक है. म्यूटेशंस में भी आपको स्मॉल और एडिनो की याद रखनी है. एडिनो अपन याद करके आए छोटू. ALK एंड EGFR1 पूरा याद किया था वो टेबल. एंड एलमिक में लंग कैंसर वो स्मॉल है. पैरानियोप्लास्टिक सिंड्रोम भी आपको याद है. हाइपरकैल्सीमिया फॉर स्क्वामस, सियाड एंड कुशिंग इज फॉर स्मॉल, ओट सेल कार्सिनोमा. बस इतना ही याद रखना है. देन IHC में यू जस्ट हैव टू रिमेंबर दिस: bombesin, synaptophysin, chromogranin. This is a marker of neuroendocrine cells. And prognosis, good for adeno and squamous. Poorest किसका बताया मैंने? Small, oat cell वाला. And this microscopy, I don't think so it's going to come, but I'll just say cytokeratin वाला जो है, जो squamous है, that is your keratin pearls. Lepidic pattern, butterfly pattern for adenocarcinoma. And azopardi effect is seen with your small cell carcinoma और oat cell carcinoma. ठीक है. ये जो lepidic pattern है, this pattern, butterfly pattern, this is also called as aerogenous spread because it is traveling via air. So direct spread है. Bronchoalveolar carcinoma, which is also called as adenocarcinoma in situ. ठीक है. After that, this came this time in the exam. The tumors of the apex. Pancoast tumor. It's adenocarcinoma or peripheral carcinoma also. So it is not that, most commonly, if you ask me that what is the most common cancer which is located at the periphery causing the complication, this is squamous cell carcinoma only. So do not think that only adenocarcinoma is going to cause, the Pancoast tumor. No. Most commonly, squamous cell carcinoma at the periphery of the lungs cause the Pancoast tumor and compresses the sympathetic of chains, cervical sympathetic chains, and therefore it is called as Horner syndrome. Horner syndrome may you have ELAM. So you have inophthalmos, loss of ciliary reflex, anhidriosis, meiosis, and ptosis. तो ये आपने ophtha में भी किया है, but this came in the exam. And it can also compress the recurrent laryngeal nerve and which can cause hoarseness of voice. So this finishes the quick revision recall of all the points of the respiratory system. I hope you read this video and then you try to learn the things. You will hear the same voice which you have done in the classes, so it will help you in remembering certain stories, certain things. Hope it helps. See you in the next show. Bye bye.